And live is a red box around your. Welcome everybody to North West Anglia Foundation Trust public board meeting today, the 20th of July. It's our first live event, so bear with us, and we will get through this agenda and you will be informed and hopefully assured of the work we're doing at the Trust. We've only got one apology, that's Gareth Tipton. Otherwise, we're all present and correct. In all public board meetings, we like to have a patient story, and today's no exception. So I'd like to introduce Laura Stent and Maria Finch, who are joining us for the offices in Peterborough, I think, today. Hello, everybody. Hi there.
Hello.
Hi there. So you're going to talk about patient story. You've got a presentation for us, but if you just introduce yourselves first, then we'll move to your presentation and then we'll take some questions.
Yep, hello, my name's Laura Stent. I'm Assistant Chief Nurse, North West Anglia Trust.
Hello, my name's Maria Finch. I'm Head of Patient Experience.
So hopefully you'll see a presentation on the screen, but we are going to talk to you today about the Adult Inpatient National Survey. We're going to look at national and then trust results, and these were published in July 2020. Next slide, please. So the Adult Inpatient Survey had 76,915 respondents. There was a response rate of 45%, and data collection was between August 19 and January 2020. The target month being that of July. Next slide, please. So the annual survey was a postal survey. It consisted of 80 questions, and to be eligible for the survey, you needed to be above 16 years of age and have spent at least one night in our hospital. There are 11 sections, and within these sections, it followed the patient journey through admission to the care on the ward and then to discharge and the overall experience. Results are displayed nationally at a percentage level and then converted into a scale between 1 to 10 at trust level. So trust results are compared to the national average, and we look at them being better, about the same, or worse than our previous year. Next slide, please.
So the national results finding were as followed. For positive finding, nationally, the NHS did really well for dignity and respect, and in the past 3 years there's been a marked improvement in all questions in this area. The second positive finding was with regards to patient-centred care, and this came between communication between staff and patients before and after operations, which has seen a positive trend in the last 10 years. And there's also been remaining very high confidence in doctors and nurses. Excuse me. Also nationally, what scored very high was fundamental needs, and that's the availability of food and hydration to our patients, and cleanliness of hospital wards and areas, and the choice of food whilst they were in patients. The areas of improvement nationally were patients discharged from hospital integrated care, which has seen a marked decrease on the results with regards to hospital discharge, delays in discharge, information about medicines and leaving hospital. Experience of admission to hospitals also see a slight decline year on year against national guidance, and then the availability of staff, where results reported sometimes there was not enough staff for the patients. Next slide, please. So for the trust, our sample size was 1,250 patients, of which we had 584 responses across the 3 trust sites. The response rate was 49%, which was above the national average, and 83% of our respondents were 55 and over. There was a near equal split between male and female respondents, and the majority of respondents are identified as Christian, heterosexual, straight, and white British. Next slide, please. Of the 11 sections that Laura talked about, which is the patient's journey, we as a trust scored about the same as the national average. So therefore there was no indicative trends for this particular trust. Next slide, please.
Okay, so the overall satisfaction of our service users was in the top 20% of the country, 8.1 out of 10, which is really good. Dignity and respect, the majority of respondents in the survey were treated with dignity and respect, scoring 9 out of 10. And then 8.5 of our patients were given enough privacy while discussing their treatment or condition, and 9.5 were given enough privacy when being examined or being treated. Next slide, please. So, positive findings for patient-centred care. Respondents stated that they had confidence in our medical team, with doctors scoring 8.7, nurses scoring 9, and clinical teams 9.1, as well as the non-medical staff scoring 9.2, which is really positive. 8.1 out of the 10 patients felt assured that if they asked the doctor an important question, they would get an answer that they would understand, and 8.5 for our nursing team. So 7.3 of our patients felt involved as much as they wanted to be in the decisions around their care and treatment. Next slide, please. So meeting fundamental needs, so the positive results of 9.4 patients being accommodated in a single sex bay, and 9 out of 10 patients positively stated that the hospital or the ward was clean, again, which is really positive. 9.1 out of 10 of our patients were given the choice of food that they required, and 9.3 had enough to drink during their stay. Next slide, please.
We scored above the national average or better than national average on 2 questions, which was question 31 and 46, which referred to confidence in other clinical staff, which includes physiotherapists and speech therapists. And beforehand, were you told how you could expect to feel after an operation procedure? We've got 8. Both of these were an increase on the previous year. Next slide, please.
So as always, there are areas for improvement, and we weren't an outlier in any of those. These were national themes. So delay in discharge. Overall, the trust scored 6.9 out of 10 in the category of leaving hospital section. And the main reason for delay in the respondents' view was for waiting for medication, which was not accompanied with clear information, either verbally or written. And then the delay to discharge for the majority of patients was within 2 to 4 hours at 40%. So I think this is something that we can definitely look at and are aware of within the organisation, but it's a national picture as well. So next slide, please.
Other areas of improvement was regarding feedback, where the overall score for the trust is 1.3. This seems considerably low, but it's on par with national findings. Even though we have an average response rate of 35% for friends and families, nationally, our patients have felt they weren't asked about their quality of care. New for the last 2 years has been the question with regards to research, where we only scored 1.2, which again is low, but nationally is also low. Thank you. Next slide.
So next steps. So we'd like to discuss these results with our stakeholders, both internally and externally. Using the national data via the survey results, we'd like to discover some exceptionally performing trusts and consider best practice as to how we could move forward with this. We'd like to host a patient experience feedback forum to collect some additional timely evidence around how our patients view us. And we also feel it's important to triangulate that trust data with regards to patient experience and create quality improvement plan to address some of the areas of challenge. We have considered adding this to our CQC action plans, just as they get monitored and reviewed regularly. Next slide, please. So these are some of the comments that were taken directly from the data of the survey. And as you can see, there's some really positive comments here about nurses and the hospital staff being lovely people. The hospital was clean, they had a really enjoyable stay. There are some comments around discharge, but I think this is around communication, and I think it's about meeting the patient's expectations and being clear, open and honest with when they should expect to be discharged. So I think there is, it's when people think that they're going to get discharged that morning, but yet they've still got their discharge letter to be written and maybe some medicines to come. So it's just about making sure that they're aware of how long these processes take, and informing our patients so that they understand a realistic discharge time, I think would be fair to say. Next slide, please. So just to say thank you very much for listening, and Maria and I would like to take any questions that you might have. We can't hear you, Rob.
Okay, sorry, thank you. We're going to stay on screen with you, Laura, forgive me for that. We're going to ask some questions around, but we'll answer them with you staying on screen. So I've got a question first from Bev, and then Joe has a question. So Bev, over to you with your question.
Hi, Laura, really good presentation and lots of positives for us to take on board. My concern in listening to this is we've got our response rate was 45%. Most of the respondents were over 55 and 93% predominantly white. So how are we going to tackle some of the diversity issues about voices we're not hearing?
So I think sadly during these strange times our patient experience groups haven't been as active as we would have liked, but we're definitely starting to look at innovative ways that we can reach those groups of people. So I think the reintroduction of our patient experience groups with potentially the use of MS Teams, for example, will give people the opportunity without having to venture into the hospital. So to be able to do it virtually may give people the opportunity which wasn't there before. So I hope that was how we would start to look at gaining some of those sort of hidden voices.
Okay, thank you. I've now got a question from someone you know, Joe Bennis.
Thank you, Chairman. So thank you, Maria and Laura, for your presentation. It was really good. So a clarifying question, really, just for the board and for the public that are listening. With regard to the same-sex accommodation, we weren't at 10 for same-sex accommodation. So I know from having read the data and just want to clarify with you both that will be some of our patients that would be in places like the emergency department, where we wouldn't have same-sex accommodation. So it's not that we're mixing sexes of patients in a normal inpatient ward.
That is correct.
Yeah, that's correct.
And just to add a comment, if I can, thank you, Chairman, to the comment that Bev has just made. We do work really closely with our Equality and Diversity lead, who has really good rail routes into some of our hard to reach ethnic groups. And so that would be a really good opportunity for us to do some co-production with our EDI lead. Thank you, okay. Chairman.
Thank you. So I've got a question from Mary, Mike, and then I'll take a last one from Sarah, if that's okay. So over to Mary.
Thank you, Chair. My question is around this outstanding feature of delayed discharges due to waits for pharmacy. And it's not a new piece of news to us. We've known about it for quite some time. But I'd just like us to try and get some powerful messages behind it, because I think if I put myself in the patient's head, they have a wonderful stay, all of the good things we've heard, lovely caring staff, and then the very last thing they experience is hanging around for 4 hours waiting for their pharmacy TTAs, and that can prejudice their whole reflection back on their stay. And I think it would be really useful to get a patient to tell us the story of what that feels like. All your optimism and excitement about going home, and then boom, you wait for 4 hours. And I'm sure if we could get a bit more patient experience descriptor of that, it might help us motivate ourselves to solve it.
Yeah, I agree, Gary. I think it's difficult, but again, I think it is about meeting expectations, and it may be the perception that you are waiting for medicines, but if they don't know the whole process, poor pharmacy get blamed, but it isn't necessarily always their fault.
Okay.
Yeah, I understand it's often junior doctor writing up and all that kind of thing, but from the patient's perspective, it's really powerful and it affects their final opinion.
Okay, I've got a question from Sarah now. So Mike and then Sarah. Mike.
Thank you, Rob. Thanks, Laura and Marie, for the presentation. Lots of good metrics in there. I just want to pick up on the discharge bit a little bit as well, though. So very good reasons for doing it for patient experience and all that. But I'm intrigued to know from the execs, I guess, around what other impacts does that have within the hospital, and what other blockages might those delayed discharges cause us?
Okay, I'm going to ask Graham to answer that one perhaps, and Joe might follow up.
So sorry, I was waiting for live. It's my fault. So overall, delayed discharges, as in lack of process, cause a backing effect throughout the whole organisation, really. So the discharge team and the complex discharge team are working on this all day, every day. And as Laura said, it's not always just that the pharmacy. It is a complex process. You know, did we have the PTDD in place? Did the junior doctor know that the consultant was going to discharge that patient that day? So it does have an impact on flow throughout the entire organisation, but we have a complex discharge team and discharge team that works through that and try and ease the patient journeys all the time. So yeah. Okay.
I think I'll leave Joe for now. I think Kanchan might have a comment linked to this. Kanchan, have you a comment?
Yes, I was just going to respond to Mary's point that this has been a long-standing problem about the gap between patients being told that they can be discharged and actually leaving hospital. The explanation, as we well know, is because of a ward round, and many people may be told that they're discharged at the same time, and then obviously all the paperwork and attention to detail, which is absolutely of paramount importance, must take place. It's not a good learning experience for the doctors not to join the consultant on the ward round, because they have to learn how to become consultants themselves and observe and follow the medical history of their patients. So whilst on one side you may say, actually, as soon as we can let a patient home, the doctor should peel off the ward round and just do the administrative work. It would be more efficient, but it's not a good learning experience, and that isn't how we teach doctors.
Okay. All right, thank you. And the last question, Sarah, you have a question.
I do, thank you, Chair. Thank you both for the presentation. Really positive to see that overall in the top 20%. And good to hear you pulling out the themes. But another long-standing theme that we see is around communication. And I wonder if there is anything there that we should be doing trust-wide around how we're communicating with our patients. And I wondered whether executives had got thoughts on whether this could be incorporated into our Good to Outstanding programme. So really standing back and thinking, how are we communicating and the way we're communicating with our patients. And if I may, Rob, the second is just a comment to say, Laura, particularly patient experiences is new in terms of your remit, and I know that you're coming to Quality Assurance Committee in September to do a particular focus on patient experience. So it'd be really good to start to see some of the actions you're taking and progress that you're being made against this there at that meeting particularly. Thank you, Chair.
Thank you. Does any exec want to respond? Perhaps Good to Outstanding, Louise, do you want to respond to that point on communication?
Yes, we can certainly pick that up at the next Good to Outstanding programme board. I mean, Graham Wilde is the executive in charge of or leading the communications work stream, and Joe is picking up the patient and caring work stream. So I'm sure between us we can follow that through.
Okay, thank you. Thank you to Laura and Maria. Thank you for our inaugural live presentation. So all went well. I think the themes came out strongly, which was I think the ethnicity of our survey. I think that fits very squarely within the work we need to do with health inequalities as well. So I think that's important. Taking all the feedback, how we can improve discharge is, we need to keep working on that. And throughout all the things we do, communication is key. So both between patients and between staff as well. So as I say, look forward to hearing an update. The next survey will be July, I guess, next year, or does it vary by month? You're on mute.
Scheduled for next July. It's scheduled for next July, however, because of COVID, a lot of things are being moved because we have about a number of surveys we do nationally each year.
Okay, so we'll pick that up, but also there might be themes that we pick up in a focused way, taking Mary's point about understanding pieces of, for example, discharge, that we could dig a bit deeper and get some more stories on that one. So I think we'll move on from that. But thank you once again, and good luck in all the work you do. So thank you. So moving on to the main part of the meeting. The first item is minutes of last meeting. So I'm looking at the minutes, of which there are 13 pages of our last meeting. This was held in March. So I want to see whether any of the pages, any of them, are you happy to approve the minutes? I'm looking around to see any comments from around both the non-executives and the executive directors. I'll leave it a moment. Okay, so on that basis, I'm not seeing any people raise their hands to me. Those minutes are approved. I'll sign them later on today. Thank you for that. Moving on to the next item is the Public Board of Directors Action Tracker. This is updated as of today, but goes back to our previous public board meeting, which is in March, and all of those have been closed. So if there's no questions, I will move on to the next item on the agenda, which is my review of the month. So I'll take the paper as read, but I just want to go through the 6 themes, which is board meetings and public maintaining assurance, triangulation, board development, the STP, and we have a new non-executive director joining us shortly. So the first I want to say is that I'm really pleased that we're able to hold the board meeting in public, even though it's virtual. I mean, there are lots of downsides to this, but I think this gives us potentially a better way of connecting with the broader community. So we will work hard with the comms team to reach out to the community to see this event live and ask questions in advance. In this process, we want to obviously be assured of what the Trust is doing, so I'm pleased to report that the board subcommittees have now returned this month. We still have challenges with the under a level for instance, but we're all meeting again. We've got focused agendas on the key topics. In addition to that, the NEDs are able to have meetings on a weekly basis with the Chief Executive and myself to pick up further assurance on a number of things, including the recovery and reset of our organisation, and estate strategy, and also staff engagement and well-being. Triangulation of that helps us seek assurance from just, not just looking at board papers is very important to us, and that's been a challenge under COVID. And whilst I understand there's lots of other areas that we can seek data from reports, I've started a conversation with Joe Bennis, our Chief Nurse, and Caroline Walker, our Chief Executive, just to consider whether anything else we can do to give us further assurance, and I look forward to response on that. And I know, Joe, we've got a question we'll answer later on today that goes some way towards that. I'm pleased to say that board development is going to start again in August. We're going to embed what we started last year. And our first session of it is to look at lessons learned from COVID. We'll look at risk management and improving that. And we're going to have a workshop on integrated care, particularly in our local community under what we call the Northern Alliance. I also want to report that we've got an external well-led review by an outside agency that will start in August, and that will support our preparation for the CQC visit, which we wait timings for. On Cambridge and Peter STP, I want to report that we're actively involved in the STP. Many of the execs are involved in some of the work streams, and we did work well under COVID. I think the system worked pretty well. So let's hope that continues. But also we set an agenda to work forward in a long-term plan. And in that, I want to make sure that I address the health inequalities that have actually been exposed during COVID. I want to encourage further system collaboration and working. And then we've really got to embed all the good work we're doing out in the community with the Northern Alliance. So we'll keep updating you on that. And finally, I'm pleased to announce that Mark Sanderson will be joining the Trust board as a non-exec director from the 1st of August this year. And that comes from a competitive review process that was approved, that Mark's approved by governors on the 8th of July 2020. So that is my report. I'll move on now, if I may, to Caroline Walker, our Chief Executive, who is going to update you on her report, and we'll take questions after that. So over to Caroline for your report. Thank you, Caroline.
Thank you, Chairman. I'd like to present my first public board report for 4 months and make the point that whilst we have been in governance light and not having public board meetings, we have been making our papers, our private papers, available on the website, and all of the 3 months worth of papers from our private board meetings in our governance light period are on our website and can be looked at by the public. So since we last gave an update, since Chairman and I last gave an update, lots has happened in tragic circumstances as we've been dealing with a worldwide pandemic. Sadly, 250 patients have lost their lives since we last met publicly, and I want to offer my condolences and those of the whole board to those families who've lost loved ones in our hospitals. So my report provides an update of where we are now and what we've been coping with and what we've been doing during the pandemic.
Just bring me back on.
Within that.
Okay, fine.
Can you all hear and see me? Okay.
Caroline, I can see you now. You briefly went off, but okay, I would continue. Yep.
I had a big warning sign flash up on my screen. So we've been dealing with the pandemic and all that lied in front of us, infection control. I want to acknowledge in this report and now publicly the amazing work that our staff have done throughout this period and the achievements that they've made and the clinical outcomes that they've delivered. I think the transformation we've done has been fantastic in the form of
okay.
consulted with.
Caroline,
I think my Wi-Fi keeps dropping down. I'm back now.
Just
the
try
connection
not
here at Hinchinbrook.
Try not move your head or anything. Just your mouth.
Because I'm interfering with the Wi-Fi. Patients and families have been understanding during this period. It's been difficult and we've not allowed many visitors into our hospitals to visit their loved ones. And I'm forever grateful for how understanding they've been and the support they've given their loved ones in hospital during this period, digitally and through written word, to allow them to stay connected.
Right.
We only have 4 patients at Hinchinbrook and 8 patients at PCH who are positive COVID, which is changing our approach, and we're needing to make a different approach as we go into the next phase. And that means we're trying to treat more and more non-COVID patients as articulated in the rest of the agenda. So we're officially in phase 3 of the pandemic. This is the period August, starting in August through to March, and there'll be more changes as we bring back more services and more patients to our hospitals. Quite understandably, during the last 4 months, we haven't treated lots of patients that we would have liked to, and they're waiting longer than we want, and their conditions and treatments are becoming more and more urgent, and our waiting list is growing. So within that context, we've got a lot to do still, but we're doing that in a planned way, and Ursula will take us through some of those plans with Graham later on the agenda. The rest of my report goes to take you through some of the things we've been doing as well as coping with the pandemic. We've been rather
Caroline.
we're trying to get through.
Caroline, can you hear me?
I can hear you. Can you see and hear me?
You keep dropping out, so I wonder whether if you turned your camera off, that might give you some better. But otherwise, I think you need towards the end of your report, and we could take some questions.
Yeah, I've just got a couple of paragraphs. Can you still hear me now?
Keep going. Yes, I'm trying to save the.
Save the power. Thank you. One of the things I was just commenting on was the fact that we've just started public consultation on relocating that urgent treatment centre to the main Peterborough City Hospital site to help improve services for same-day urgent care for the population of Peterborough. And the other thing that we're progressing ahead with on our strategic projects is the redevelopment of our Hinchinbrook site. Phase 1 of our hospital redevelopment on that site is underway and partially completed with the expansion of the ED, the ambulatory care unit, and the minor injuries part of that site. We're progressing with our business case for the phase 2 and phase 3 of that redevelopment, and I'll keep the board updated on that further as we go along. The next part of my report is about car parking, something that we have discussed many times, and that's something that we've started our plans to implement our green travel plan again now that we're coming into the next phase of the pandemic. So we'll be progressing our green travel plan, and part of that is to change our car parking, and we will reinstate our car parking charges for patients over the next few weeks as we bring more patients back to the hospital and reconfigure our car parks to cope with that. Finally, my report, as I always like to end on a positive, with lots of the tragic, sad circumstances we've had for the last 4 months. The positive is that lots of great things have happened, and I've just shared a few snippets with you at the end of my report out of hundreds and hundreds of great things and hundreds of heroic things that our staff have done during the last 4 months. And I just wanted to share a few of those with you at the bottom of the report, as I have done, not least of which the achievements we've had on the research and the trials that we've done and the things that we continue to do on that basis. And I'll finish with a thank you. It's been a challenging 4 months for us while we haven't been meeting publicly, and I wanted to say thank you to my executive colleagues and my non-executive colleagues for supporting me as chief executive throughout that period. Couldn't have done it without you. Thank you. Okay,
thank you, Caroline. I think we got 80% of what you were saying, and I think we've read the report. So I think we have a Wi-Fi issue at your location, but we'll continue because I think we heard most of that. I also want to thank, because we thanked in other meetings, but I think that publicly I want to thank everyone for the excellent performance throughout COVID, and it is not going to notice, not just by the board but also by the regulator. So once again, thank you for that. So I'm happy to take some questions on your report. I'm looking around to see if we have any questions. I'll leave it a moment, otherwise I will move on to the next item of your agenda. So I think we'll move on. I think I'll just finally comment on, I think you've taken through a number of things, not just the redevelopment work, the COVID work, but also the other additional work the trust has done. So, and I guess we'll hear more of that in the paper when we look at strategy, etc. but I'm happy to proceed now to the next item on the agenda. Thank you, Caroline. We're going to go through the integrated performance report. We're going to review it. The way we're going to do this, there's a lot of information report in the background. So the way we'll deal with this is that we will ask each executive director to lead with the summary that they've produced at the front of the report. We'll do quality first, and then we'll take questions. We'll have additional feedback from the non-exec directors. We'll take a few questions for clarity, and we'll work our way down through to workforce. So without further ado, could I then go to Jo Bennis, our chief nurse, who will take us through the quality highlights. Thank you, Jo.
Thank you, Chairman. So just to make sure everybody's clear that we have continued to have the Quality Assurance Committee during the whole of the pandemic. It was one of the sub-board committees that wasn't put on hold due to governance light. So we have been given assurance around the quality of care for our patients. So just wanted to highlight some escalations within the quality report. So just to say, from a serious incident perspective, in June we had 9 SI reports that were due to be submitted, with one requiring extension due to the capacity within the clinical risk department. I've had quite a lot of my team, as others have, been redeployed to clinical areas during COVID, so it has left us depleted in some of the corporate teams. We are undertaking a huge amount of work on the action plans that are aligned to the SIs, and have good oversight now from the divisional and corporate action plans and outstanding actions. From a complaints perspective, themes identified for further investigation into complaints is that when our complainants seeking further clarity on outcomes and findings, their requests for virtual local resolution meetings, and when they first get their complaint response, that generates quite often for them further questions that they need answering. With regard to falls, my falls nurse specialists have been on critical care during the pandemic, and although we see our crude number of inpatient falls remain high, we have been doing a huge amount of work to review the falls that we've been having during COVID, and have spoken about these in detail at Quality Assurance Committee previously. What we have found recently is that a small percentage of the falls that we are recording is related to the wrong PIC code being chosen, and we're just in the process of validating that data at the moment. We've also seen an increase in the acuity of frailty of patients admitted within June, and that's had an impact. And during the pandemic, because we've had red and green areas, so COVID receiving areas and non-COVID areas, we've had a real mix of our staffing levels and the types and specialities of patients that our clinical teams have had to care for. And we've also not been able to have our normal support mechanisms in place, like the apprentices, dementia volunteers, and most importantly, some of our family members who take on a carer's role for this vulnerable cohort of patients. But we are working on educational sessions for the teams, and the team are all back to full establishment now, and getting on top of all of our falls. From a pressure ulcer hospital acquired perspective, we've seen a decline in the number of hospital acquired pressure ulcers in June, and it's the lowest since October 2018. Whilst this is really good news for us, there are still lessons to be learned, and a lot of the evidence has demonstrated that COVID and the effects of COVID have meant that more patients have been prone to developing pressure ulcers. Infection prevention and control, there's lots more detail within the pack, but the key area that I wanted to highlight was around the MRSA bacteremia that we had in month. During COVID, nationally, we were asked to reduce the amount of MRS screening that we undertook within the organisation to enable the labs to cope with the COVID testing. The patient that developed the MRSA bacteremia wasn't deemed to be a high-risk patient, so wasn't screened during this period. We've done an analysis and a review, as we have to for every case, and identified the learnings from that. One of those would be to reintroduce MRSA blanket screening again for all of our patients as business as usual. From our hospital standardised mortality rate, we've got perinatal conditions and pneumonia alerting. And from a maternity perspective, we've had a detailed conversation at board this morning around our CNST year 1 and 2 compliance, and also the internal review that we undertook. From maternity KPIs, we're seeing that our induction of labour rates are higher than national average at the moment, and we are reviewing this on a monthly basis. We've had 2 birth injuries for the babies recorded in month. Both birth injuries were at Peterborough. One was a baby with a partially fractured humerus of unknown origin and a skin laceration instrumental delivery. So we are currently looking at the trend and themes of birth injuries over the past 6 months on both our maternity sites. And we had 1 full-term baby that required therapeutic cooling, and this was a baby born at Peterborough unexpectedly in a poor condition. What we have found, fortunately for the baby, is a subsequent postnatal MRI didn't demonstrate and evidence any ischemic brain injury for the baby. On looking at successes for us from a quality perspective, lots of work going on with duty of candour at the moment, and making sure that all of our serious incidents and cases that require duty of candour to be undertaken are undertaken with our patients and next of kin as required. We've still some more work to do on the DATEX that are graded 3 and above, but we are working through the nuances on the system with the divisional heads of nursing and the teams. From a complaints perspective, we have seen our volumes of complaints resuming to near average levels following COVID. So we had 60 recorded in the month of June, and I'm really pleased to say that 100% of those complaints have been responded to within the agreed timeframe. And despite telling you about our falls, we have seen a reduction in month, even though they are higher than we would like them to be. And the inpatient falls per 1,000 bed days has also reduced, and the level of harm. We've seen a reduction in the pressure ulcers, and we are starting to see a reduction in our hospital standardised mortality rate as well. From a risk perspective, I just want to highlight the risks from quality assurance, which is around the reputational impact of our non-compliance with our year 2 CNST submission for maternity, some vacancies within the maternity leadership structure, and some vacancies and our impact on the midwife to birth ratio at the moment. So thank you, Chairman. Okay, thank you for that report. I think you've given an insight into the journey that you've been through in terms of the restrictions that COVID has actually given you, but also how you're trying to sort of bring things back to normal. So thank you for that. I want to turn to first of all Sarah Dunnett, who'll take you through the response as committee chair for QAC, but Mary Douglas will also respond. So firstly, I'd like to go to Sarah. Thank you.
Thank you, Chair, and thank you, Joe. Yesterday at Quality Assurance Committee, as the board is aware, we scrutinise not only the quality report, but all of those reports that feed into it. And we are assured that on areas where we're not performing where we'd want to be, that clear action plans are in place to address performance. I would also like to highlight that on staffing, no concerns were raised with staffing, be it medical or non-medical, in relation to quality. In relation to safeguarding, the Trust has adequate resources in place for safeguarding, but the board should note the demand is increasing, particularly in relation to domestic violence incidents. Jo, as Chief Nurse, has already commented on infection prevention and control. And again, the committee continue to monitor not just outcomes, but also progress we're making on implementing action plans as a response to tightened infection control that have resulted as COVID has happened. There is a particular focus on cleaning, and the Trust has currently got a funding bid in to increase the levels of cleaning in some parts of the hospital. Really pleased to report that the risks, we see the quality risks at the Quality Assurance Committee, and the risks are up to date and in date. And this month we saw a merger of the risk register and the separate COVID risk register. So we are now just looking at one risk register. There is one uncontrolled risk that's currently on the register in relation to COVID, and members will have noted that later on in the board papers. And that is currently under review as part of the overall lessons learned and capacity planning work that is currently ongoing. We also agreed at the meeting the clinical audit plan for 2021, and were assured as a committee that it was consistent with the national audit plan and priorities for the Trust. We also received a report on health inequalities produced by, at the request of the committee, by the CCG, which is consistent with feedback the board has been receiving over the past few months, particularly in relation to challenges we face in the north of Peterborough and Cambridgeshire around respiratory pathways. And I know the Director of Strategy and Transformation is taking forward work around this. Particular focus of the committee, as the Chief Nurse has already highlighted, is around maternity and around mortality. And if I may, Chair, I'm going to pass to Mary, who is the lead NED for both of those areas.
Thank you, Sarah. Within mortality figures, there are two figures that are used. One's the HSMR and one is the SHMI or SHMI. Both of these figures have been a subject of our consideration over several months. The SHMI is rising and is statistically significant. The HSMR actually this month was down, but is still significantly high. Within both of those two figures, we get month-on-month variation, and as already mentioned by Jo, in the most recent month, we had a concern or alert around pneumonia, and equally so, we've seen a reduction in, for example, congestive heart failure on the Hinchingbrook site. So what we've been doing over a period of time now is trying to get to look at these figures, because both of them will reflect not only our quality of care, which of course is the most important part of it, but they may well be affected by the coding of the particular diagnosis and or the type of admission that a patient experiences, whether it's under a full stay or a short stay under 24 hours. We've been doing a lot of intensive work with the aid of Dr. Foster, who reported at the last committee, who came with us and took us through all of this. And their input has massively improved our understanding of the coding and the admission issues. However, we've put all of those issues into a mortality reduction plan, which is in the process of being finalised, because the figures are one part of it, but we don't want to in any way pass off any other concerns that we need to look into. So mortality reduction plan is being finalised, and it will cover all of those elements.
Thank you, Mary. Just moving on, any questions around on the quality paper that you've received? Okay. Yeah, lots of very clear work, lots of assurance going through. I think mortality, there's an action plan in place to progress that. That's going to come back through QAC. We look forward to hearing further report when that is progressed. So I now want to move on to the next item, which is to our Chief Operating Officer, Graham Wilde. So over to you for your report. And again, we'll follow that with Bev, who will give a response from the non-executives. Thank you, Graham.
Thank you, Chair. I'll take the report as read as normal. The things I wanted to highlight this month are that the A&E attendances at all of our sites are coming back up to almost pre-COVID norms. So we're back at 90% of attendances through our EDs. Yet, despite that, we continue to maintain good performance, well, excellent performance above the required 95%. And I think it's, as we touched on earlier in the meeting today, it's worth noting that that's not just ED. The flow through the organisation is essential to maintaining performance in the emergency department, as well as through the rest of the organisation. So the fact that we're maintaining such a good flow through our emergency department is testament to all the hard work that's being done across our wards, our departments, our diagnostics, our discharge teams, and everybody, as we have got good and consistent flow through the organisation. I think it's worth noting that. On top of that, though, particularly within the ED department, we are seeing our lowest ever ambulance handover delays since 2018. And I think that's well worth noting, that the team have come so well and so far, despite having also to deal with a pandemic. On the less optimistic, on the less upside, our 21-day length of stay is starting to go up slightly, and that's predominantly affected by the need for patients to remain in hospital if they have a negative COVID swab upon discharge, and we're trying to work through with our partners how we do that, but that's having an impact on our length of stay. If I move on to talk about the elective side of our work, the number of patients that we've been treating through the COVID pandemic has remained high. We're seeing a slight decrease in performance this month in terms of the cancer performance, but that's mainly because colleagues will remember that the number of 2-week wait referrals went down at the height of the pandemic, and we're working through that now. So because the target is a percentage, we're seeing less people, and therefore it's having an impact on our performance. Just highlight, as I would normally do, that for those who are listed on the 104-day cancer waits, each of those patients is actively tracked on a daily basis, and we know where they are on their pathway. I'd also like to point to one of the other slides around the recovery work that we've been doing on the pandemic. We've mentioned that we're now moving from phase 2 into phase 3, and we were set a number of targets and aspirations to hit by the end of this month, by the end of phase 2. And I think it's worth noting that the teams have delivered excellently against their targets. So in terms of imaging, we've exceeded the asks that we had. In terms of endoscopy, we're not quite there, and we know that we have problems in endoscopy, but we are showing improvement week on week. In outpatients, the slide in the pack shows we're just short, but actually we've now exceeded that target as well. Our elective activity remains above what was required of us by the end of July, and our A&E attendances, perversely, we're not at the target, and I'd like us not to stay at the target, because that was to get back to the pre-COVID levels of attendance, and I'd like our attendance to stay lower than pre-COVID. I think it shows that our populations around us are learning that there are other ways of meeting their health needs, be that local pharmacy or self-care. That's all I wanted to highlight.
Okay, thank you, Graham. So I'm going to move to Bev now, who's going to give a response from the non-executive directors, and then we'll take some questions. So Bev, do you want to, Bev Shears?
Yes, thank you, Chair. This was our first people and performance meeting through Governance Light. We have obviously been kept track of performance through quality and through private board. But it was really pleasing to see the A&E performance. I'm going to blow Graham's trumpet a bit for him, where for the 4th consecutive month, it's been extremely strong and met targets. The things that were put in place before we went into the pandemic are clearly starting to bear fruit. It would be good to see as we go through that as we transform out of the COVID thing, that's maintained and is strong despite the challenges that we probably face ahead. Ambulance performance was noted as strong by the committee. We were also pleased to see, whilst it straddles performance and quality, we were pleased to see that risk stratification and outpatient waiting lists have been validated and managed through the system and carefully curated to ensure that the right outpatients are being prioritised. Our RTT reporting is, we agreed this morning at private board, the recommendation from the committee that it should commence reporting in August. That was good to see that being put in place, and we're also very pleased to see the mandatory RTT training being implemented throughout the trust to ensure that as we move back to reporting RTT, that everybody, clinicians and non-clinicians, understand the way the system works on RTT. So we did have a new governor join us, but after introductions, unfortunately, he had to bow out because of technical problems. But it's good to be back in the public domain and proper committees again. Thank you.
Okay, thank you, Bev. I've just got a general question, because this is a board meeting held in public, and the public will be either watching us now or listening to us later on. And I just wondered, Graham, or whether anything executive directors could just give a simplistic view on where we are as a trust in terms of getting back to normal. And you mentioned sort of 104-day cancer patients, you're keeping track of them. So any sort of little insight you can give to sort of explain where we are currently?
Okay, thank you, Chair. It sounds a little bit of a truism now because we're so far into the pandemic, but I guess I would have to talk about the new normal. So all of the processes and so forth that we had in place pre-COVID, as far as we have been able to, we have stood them all back up. So risk stratification for our waiting list. So
Greg, just clarify risk stratification to the public, what that means to them, yeah?
So, yeah. So risk stratification means that rather than just treating people in date order, in the order that a referral would come into the trust, the referrals are looked at by all of our senior clinicians, and they are prioritised in terms of clinical need. But because that is a point in time, we also keep going round that process, and that's what we mean by risk stratification, to see if somebody's clinical need has altered while they've been on the waiting list, and so therefore they need to be moved up the list. In normal times, we still did that, but it wasn't as large a task. Now, because of the we've had to slow down our treatment because of social distancing and other factors, the waiting list has the potential to grow larger, and therefore the people on the list, their clinical condition has the possibility of changing whilst they're waiting. So we go back round that, and that's called risk stratification.
Thank you, Graham. Okay, thank you. So things are with a new norm, and we're trying to make sure that patients that need care urgently will get it, and particularly we are looking at the lists of people that we need to check with. So thank you for that. So I've got two questions, one from Sarah Dunnett, and then we're going to have another question from Mike Elwood. So firstly to Sarah.
Thank you, Graham, and thank you, Bev, for the report. Graham, I've got two questions. The first is, and you didn't touch on it, so I'm sure you covered it in people and performance, and do tell me if that's the case. But emergency readmissions is flagging red on the dashboard, and my question is that a care issue. So, for example, are we discharging people too quickly and they're then coming back to us as a readmission? So that's my first question. And my second question is helpful to get the overview in terms of risk stratification. I just wondered what sort of contact we have with patients who are obviously anxiously waiting to know when their treatment may take place. So it'd be helpful if you could give us a feel for the type of interaction and communication we've got with patients who are on our wait lists. Thank you.
So back to Graham, I think, yeah.
So of the two, the emergency readmissions, although, and this sounds a very cold answer, although showing a slight 0.4% increase over the last month and is just slightly above our upper control limit, at the moment hadn't flagged for concern. But I'm happy to take your concern back through the operational teams and see if I can identify a perhaps emerging cause or special cause that may have changed that factor. So I'll take that back through my operational teams. In terms of the waiting list management, so it comes back to Rob's earlier point around how is the new normal coming back. So that's one of the things that we've stood back up. So as the teams are able, they are constantly phoning patients on the list to keep them updated. There will be inevitably, because of the large numbers involved, the odd person that we miss, and we monitor complaints and so forth to look for those. And we're also talking to GP practices, particularly in the north, around whether they feel there are any issues between their referral and the patient being contacted. So we're trying to tackle that from several different ways.
Okay. Thank you, Graham. I've got a question from Mike Elwood now, then we'll take a comment from Ray, and then we'll move to the next item. So, Mike.
Yes, broadly, my question was the same as Sarah's second question, but was initially sparked by the thought process of risk stratification, and it was that individual who may continually be bumped down the list, and whether we also have a lens on how long or how many times that has happened, and whether that gets brought into that communication strategy you talked about, Graham.
Yes, so again, normally we'd be monitoring that and trying not to move people more often. At the moment, we're having to prioritise clinical need above length of wait. And when we go back to reporting the RTT position, you'll see the impact that's had on some of our long waiters. But we have got actions in place and are hoping to start tackling those long waits for perhaps not as clinically urgent procedures.
Okay, thanks, Graham.
Okay. Before I come to Ray's comment, just keeping you on screen, what you describe is probably an approach that's taken nationally in terms of waiting lists and clinical need taking priority. Is that correct, Graham?
Yes, I mean on the there are several coup networks regionally and nationally, and each organisation is trying to balance the clinical priority against the need to have to step down capacity to keep patients and staff safe in this COVID world.
Okay, thank you. And finally, I want to go to Ray Harding for a comment. Thank you, Ray.
Thanks, Chair. It's really just to reinforce the performance in ED. I know that the numbers were obviously down, but they're now increasing back towards normal levels. But we've seen a sustained improvement in performance there, and I think that's down to the issues that have previously been discussed, such as leadership, patterns of working, and I think what we're seeing is a sustained change in culture there, which will stand us in good stead for the future. So I don't think we should underestimate the progress that's been made by the executive in that area.
Okay, thank you, Ray, because you also sit on the performance committee as well, and you'll have seen that information. So thank you, Graham, for your report. I think good progress, but equally the message that there's a new normal and we're working as hard as we can to get capacity back as best we can, given the limitations of having, to be able to respond to outbreaks of COVID, etc. So thank you for that report. I'm now moving on to the next report, which is finance, and I'm inviting Joel Harris to take us through the report. Thank you, Joel.
Thank you, Chair. Much like other areas of the hospital has been described by executive colleagues this afternoon, finances is also a little bit different at the moment as a consequence of the COVID pandemic. So nationally, the Department of Health and NHS Improvement and NHS England introduced a financial framework to support providers, particularly during the COVID pandemic period, that initially covers the month 1 through to month 4 period. So that's April through to the end of July. So in March, the Trust is reporting a break-even position for month 3 and a break-even position for months 1 to 3 year to date, and that is in keeping with that national financial framework and the extent to which the Trust is supported with its expenditure. Prior to the inclusion of the additional true-up payments from the national teams, the Trust reported a £6.8 million deficit in month 3, and year to date is reporting a £12.1 million deficit. During June, what we've increasingly seen is as the intensity of the pandemic starts to reduce and increased activity starts to return to the hospital, particularly non-COVID activity, and as Graham talked about, a lot of that is in planned care areas, our expenditure profile has started to shift, and we've seen an increase in pay costs as we start to bring back activity, and an increase in some non-pay costs compared to that month 1 and 2 period associated with particularly increased surgical activity, which is a good news for us as we start to treat more of our patients. For June itself, we reported 4.9 million incremental costs associated with dealing with the COVID-19 pandemic, and again, month 1 to 3 year to date, we've reported 10.1 million of costs above our baseline associated with dealing with the COVID pandemic. So moving forward, our focus as an organisation, as we particularly start to operate in this new normal, as has become the phase as we start to come out of the COVID pandemic, is to focus on how we manage and understand our run rate, linked to our recovery plans, which we will come on to talk to you about, and how we shift our focus to using our available resources to be able to deliver as much activity through our available resources as possible. Supported by the national framework, we have a cash balance at the end of June with £73 million, which is a slight decrease compared to the previous month, and we continue to support the national supply chain strongly and have particularly strong improvements against the Better Payment Practice Code, which measures how quickly we're paying our suppliers to keep that supply chain working nationally. In terms of our capital programme, we've spent £8.1 million year to date, of which 3.8 million in particular is on COVID related capital, and the capital programme, the total capital programme, excludes our COVID related activities as we have to deal with them as they arise. So we're reporting about £4 million against our £28 million capital programme for the year. Happy to take questions.
So before we do that, thank you, Joel. Ray, have you any additional comments you want to add as chair of the Finance Committee?
Yes, please, Chair. The committee met for the second time since the lockdown. We had a meeting the previous month to look at the overall financial planning. And although financial planning instructions have yet to be finalised, an interim financial strategy was recommended to the board for its support in terms of working largely on the basis of the previous draft budget assumptions as adjusted in the first half of this year for COVID, and that was supported at the private board, as was a capital expenditure item recommended as being above the value which the Finance Committee has authority for £422,000 for the nerve centre, particularly regarding Hinchinbrook and bringing Hinchinbrook up to the same standards as Peterborough. The key issues coming from the meeting were the financial performance at month 3 was break even, as has been indicated. That was in line with instructions because the underlying deficit is effectively funded by the NHS for the moment. It's worth noting that in those costs, the COVID expenditure represented more than 8% of total expenditure, about 8.3%. Month 3 has recognised recent pay awards, and so that's obviously inflated figures, and that includes also the implications for the PFI contractors. For the first time, we looked at estates' key issues as a whole in this committee, rather than merely the financial implications relating to estates. And for the moment, estates will report through the Finance Committee as the relevant subcommittee of the board. In terms of risks, that we reviewed, one of the main things is that the pay run rate, which has necessarily increased because of COVID-19, it may be difficult to take out of the system. Obviously, our biggest single cost is pay, and pay is notoriously difficult to reduce. It's not discretionary payment. The other major risk coming from the estates review related to Hinchingbrooke panels, where we're replacing the concrete panels as reported previously, and we're seeking to bring forward the replacement of the theatres to avoid an inefficient repair programme there. And the other risks were reviewed for the finance and estate matters and were considered to be adequately mitigated at this stage.
Thank you, Ray, for your report, and thank you, Jill, for your report. I'm looking round for any questions which I can't see, so I'm assuming that we are content with what we've heard. I think that what I'm hearing is that we've got month 1 to 6 where there is support, there is we are doing all we can financially, but there's lots of uncertainty, and therefore what you're doing is to put in place a financial strategy interim going forward that at least keeps us focused on the right things, so we make sure that our spend remains under control. So good to hear. I also hear that we're also working on estate issues and initiatives, so that's also good to hear that's been looked after as well. So thank you for reports. I'm now going to move on to Louise, who's going to take us through workforce and OD, and then Bev, you can follow up with any comments you wish to make from the People Committee. Thank you. Over to Louise.
Thank you, Chairman. So just looking at the workforce summary in the slide pack, just to pick out a few key points really. We've seen some increases in sickness absence, as you might expect, through COVID. Went up slightly in March, and it's really continued on a steady throughput all the way through to June. We know that we've had a number of staff off work sick with COVID directly, but we know that a number of others have been impacted through stress and anxiety, and that has also not helped with our numbers. We're supporting people back to work as quickly as we can, and we want to make sure they get any help that they need to return to work. The other areas that have suffered really due to COVID are around non-medical appraisals particularly. So managers have been focusing solely on frontline delivery. We've now asked them to pick this back up and make sure that we improve our compliance levels and get right back to where we need to be. So that's currently a focus out there in the divisions. And the other one I just wanted to pull out was time to hire. So we were doing really well actually at keep reducing and pushing down our time to hire. The recruitment process has not stopped through COVID. We've continued as far as we possibly could, using technology to interview people and to keep attracting, but we've hit a bit of a backlog now with visas. So for just one division, for emergency and medicine, we've currently got 70 doctors sat in a visa queue. So as countries are starting to process, and as our own country is starting to open up immigration, there is a little bit of movement, but I know that that's a problem across the country, so we'll keep that under review. There's just two other slides in the main pack that I wanted to draw your attention to. One is page 103, which is page 100, which is the COVID risk assessment. So board colleagues will know that we've been really keen to make sure that we risk assess all staff in the trust. There have been national requirements, lots of national guidance, lots of changes to national guidance. We've been on a bit of a roller coaster along with everybody else, but we've now got a target to risk assess 100% of all staff by the 31st of July. The figures that are shown on the slide are showing that we've got 54%. Actually, as at yesterday, that had increased to 79%, and the team are pushing on. I don't think we'll get to 100% because we will have staff who are off sick, on maternity leave, etc., and we will not have been able to do that. This is really important. So it's been taking account of the guidance about gender and the differential impact of COVID on different age groups, different genders, but particularly for Black and minority ethnic staff, and of course those with underlying health conditions and those who may be pregnant. So we've been going through a process. This is something now which we're required to repeat those risk assessments every 3 months. I'm not sure that managers have quite realised that, but they will be, and we're pushing on and we're completing national returns. Really important because we do need to take, we've got a duty of care to our staff, and we need to take whatever actions we can to minimise the risks for them. So I just wanted to share that. And then the other slide that I wanted to share is 103, which is the quarterly cultural barometer, which we've been doing for some time. And I've included in here the barometer from Q4, so that was the January to March, and also Q1 for this year, which is April to June. We're doing some work now to understand what this might look like for all the divisions, and we've got site-based information, working with managers, and of course the Good to Outstanding Programme Board, Hospital Management Committee and People and Performance Committee have governance oversight of this, but I thought it'd be helpful to share. So whilst we have made some gains, some of them are quite marginal, the one that has increased and has gone amber is number 7, which is I'm proud to work for our trust. I'm still particularly concerned about number 2, which is how likely are you to recommend the organisation as to friends and family as a place to work, because recruitment continues to be a challenge. So it's, the colours aren't much different. There is a significant shift from a red to an amber for one of the quadrants, but actually if we couple this with other work that we're doing around lessons learned, medical engagement survey, staff survey, we're going to be taking an action plan, the first cut of an action plan, into the Good to Outstanding Board in August, and then we'll overlay that with more detail as we move through to September. So I thought it'd be helpful to show more work to do on some of that, and we really need to make sure we're taking heed of what staff are saying and, more importantly, feeling. That's all I wanted to say. Happy to take questions. Thank you.
Okay, thank you, Louise. Let's go to Bev first, then I've got Mary will have a comment, and then we'll take some further questions. So Bev.
Thank you, Chair, and thank you, Louise. Firstly, it was a really good meeting. There are 2 items that we escalated to board. That sounds like a negative thing, but they're on the agenda, which is the health and safety report, which we scrutinised, and the COVID recovery plan. So I'll let those stand on the board for discussion. One of the concerns we had was the MPA, the appraisals for non-medical staff. The scores remain low, and we understood as a committee that that might be a challenge during COVID, but we triangulated it with the cultural barometer survey, which is telling us that on our 2 reds that people don't feel they can contribute, opportunity to contribute, and don't have the conversations with their line manager and access to line manager. So we had a good discussion about triangulating that and linking it to our COVID recovery plans, so that all the positive things that came out of culture during COVID are harnessed, and we use the opportunity to give feedback, listen to feedback, and set a tone in the organisation where appraisal is seen as a good conversation, not just a process. So that was a good discussion, and Louise assured us there were plans in place to do that. The phrase we used is appraisal in the DNA rather than a once a year activity. Time to hire, whilst Louise was right to highlight it, there's obvious reasons why it's been set, and in risk terms some of the reasons are outside of the trust control, for example immigration visas, but we will be paying attention to it over the coming months, because obviously there are some difficult to fill roles that we need to progress, but also ensuring that we we do keep filling our vacancies. I think that's all I have to say. At People and Performance, we did obviously review the BAF and risk registers as they were reviewed and noted. So I think it was good, again, good to have our first meeting, albeit by Microsoft Teams, and good discussion.
Thank you, Bev. I think, Mary, did you have a comment, or did you not have a comment? Can I just check with you?
Yes, I do have a comment, and it's actually just to commend a particular part of this report, if I may, and it's about mandatory training compliance, which has been maintained absolutely consistency throughout the whole crisis. And I find that completely amazing, because under these kinds of pressures, it might be considered to be very mundane and unimportant. So it is a remarkable achievement. I just have one little concern and wonder, or maybe it's a learning point, and I wonder if it's been easier to maintain mandatory training through online work when people are working from home, rather than when they're trying to squeeze it in during their frontline jobs. So it might have been disproportionately achieved from, say, admin staff versus frontline staff. But it is good. I just look to see how it goes forward in future.
Can I respond to that, Rob? So I think, we haven't had armies of staff working from home, but we have encouraged managers to get staff to do the mandatory training. So if we've staffed up for a lot of COVID, and actually we haven't quite had the throughput of patients, they've had a little bit of capacity, we've encouraged them to catch up on the housekeeping. But there's no doubt that we've encouraged staff at home who've been working at home to do that as well. What we do need to take mind of, and I've got my team looking at this, is looking at compliance at staff group level within each CBU and also on subjects. So I think the high level could mask some gaps in there, which we now need to address, and we're starting to bring back mandatory training in a face-to-face capacity wherever we can.
Okay, I've got a question from Mike, and then I'll close with a comment from Bev. So Mike.
Yes, just very quickly, Louise, agency rate sort of snuck away without a comment here, but it's quite an improvement when you look at the trend over the period. Is there anything exceptional around the period we're in that allows us to achieve that, or is that just a continuation of our efforts?
Well, I'd like to say it's all the latter, but I think it's probably a combination of the two. So, of course, we're continuing to put controls in, but actually the way that we have redeployed staff through the crisis has meant that we've taken some services down, we've redeployed some staff to other areas. There hasn't necessarily been the need to bring in agency staff. And actually we have seen, where we have tried to get agency and bank staff, we've seen our fill rates drop. So whilst we're holding firm on pay rates, we've seen the fill rates drop, which could be a feature of that, but there hasn't always been the need.
Okay. Thank you.
Thank you. So let's go to Bev for one last comment on this part of the report. So Bev, over to you.
Yeah, thank you, Chair. I got cut off momentarily, so I just wanted, you may have covered it in your answer to Mary, but Mary, mandatory training we paid attention to, not from the headline figure, but the fact it masks a number of areas that are persistently not meeting the standard. And Louise has an action plan, and we were assured on the action plan for reaching into those areas. I hope that built on your point rather than repeated it. Thank you.
And actually, if I can, one more point, Chair, if I can. So actually, through the new performance and holding to accountability framework that we're beginning this month with divisions, those sorts of things will be in there. So we'll be expecting them to give us further assurance that they are tackling the detail, not just the high level data, if that makes sense.
Okay. Thank you for that. Just to close this part of the IPR, just want to acknowledge that your report is a reflection of the hard work that staff have been having to do. So it's been a very stressful time for many of them, and so again I want to thank them for all the work they've done, and thank you for your report, but also focusing on the key things. And it's good to hear about the have your say feedback, but also hopefully we'll get those doctors that are waiting in the queue to come and join our trust shortly. So thank you for that.
Thank you.
So thank you. I want to move on now to Shears, who's our Director of Strategy and Transformation. Her first public board meeting. So over to you to take us through your report, Shears. Thank you.
Thank you, Chair. So just a few key messages for strategy and transformation. We don't have a dashboard for strategy and transformation, which we'll be looking to develop in the next few weeks with a view to having it back to the full public board in September. So key things, 3 key points from me. Number 1, in line with the Cambridge and Peterborough strategic plan, we have made really good progress working with our system partners on making some of the patient journeys more seamless, and especially for the long-term conditions and for diabetes, cardiovascular and respiratory that we know are more prevalent in our population. We've been given some funding for diabetes, and we hope to see some of the results from this and report to the board in September. The second point I wanted to make and share was around the North Alliance Program Board on outpatients and diagnostics. And again, really good progress working with our primary care colleagues, community colleagues, and how not only we recover activity post-COVID, but also transforming the pathways going forward. And then finally, Chair, on transformation, as a board, we've agreed the priorities. Now the next step for us would be to take some of the priorities forward, and the key ones for us, as you've been hearing from Graham, how we get activity back and some of the other stuff that's been discussed so far. It's based on how we do things differently in outpatients, urgent emergency care, and also, of course, the integrated pathways. So that's all I was going to say, and hope to bring a dashboard and more detail for the next board.
Okay, thank you for that. Any questions or comments? I think that we wish you well. I think you've made an impact in the short term you've been here. I just want to record that, and I think that we've there's a lot of things that we are focusing on, not just inside the hospital, but more importantly outside the hospital. So we'll hear more of that as we progress going forward. So unless any questions from that, I'll move on to Taff Giddy, who's our Company Secretary, going to take us through the next 2 reports related to governance. So thank you for Taff. Thank you.
Thank you, Chair. In relation to my reports, I'll just note that I've got information that's in the IPR report, and I'll pick up key points from that. In addition, I also have 3 reports that are attached that I'll take as read. One is the revised board assurance framework. If you remember from the conversation that we had at the last board meeting about the impact that COVID had on our board assurance framework in terms of timeline and delivery, and the board agreed for the executives to take away and make some revisions to the board assurance framework to reflect that impact. We're bringing that back this month for board approval. There's the usual monthly risk report. The only thing I'll add in relation to that is we've combined now the normal risk report with the COVID risk report, but we are still, for all the risks that are high or significant and COVID risks, we're still reporting all of them in the same way that we're doing when we're 2 separate reports. And lastly on that, there's obviously the modern slavery statement that will also require board approval as well. So in terms of the integrated performance report, then I wanted to start by just picking up the 2 sort of positives. Firstly, on high and significant risks, I'm pleased to report that again for the 2nd month we've achieved 100% compliance on making sure that all our high and significant risks are up to date. This is positive news, especially in light of the conversations that we have had about making sure that we improve embeddedness of risk management through the trust. We're starting to see some green shoots on that, which is credit to Paul and Jo and her team for all the work that they're doing with the teams around risk management. In addition to that, we continue to do some collaborative working with the chief nurse, the intention being that we have a consistent approach and can share some learning between the corporate governance teams and the clinical governance teams, and that is working well as well. And we're starting a lot of the improvements that we're seeing are in part because of that collaborative working. The risk reports that are attached at the back, I will note that these reports will have gone through the subcommittees, and any issues from the subcommittees would have been picked up. So I'll take any comments from the chairs if there are any concerns that came from the subcommittees, but I'll take it as read. The modern slavery statement is a requirement by law that we should have one that's approved by board and then published on our website. Paul and Kim have worked diligently on my behalf to pull this together, learning from other trusts in terms of what that looks like, to pick up on key areas about what we're doing, for example, around our supply chain, our staffing, and also in terms of things like safeguarding, where these are the areas that would help us pick up if there's any areas that we should be flagging and reporting. So hopefully the trust will, the board will approve that so we can publish that on our website. And lastly, I wanted to pick up, and Mike might want to pick up on this as chair of the audit committee, is what's included is the internal audit plan that's been revised. Again, the impact of COVID was that at the end of March, the Director of Finance agreed with internal audit to pause any work that was in train for Q1 so that the trust could respond to COVID. We've now started back to have internal audit, but that impacted on all the work that was due to be done in Q1. We have now revised some of those dates, and the plan that's in the pack reflects those changes, which have been taken through the audit committee and have been approved. And on that, I will take questions.
Okay, thank you for that. I think you referred to Mike coming in, but I've also got Caroline, where I may have missed a question come from Caroline. So I want to go to Caroline first. I then got Bev and Sarah following, and then we'll also speak to Mike. So first of all, Caroline.
Thank you, Chairman. My comments were in relation to the strategy, but I do also have a comment about TAF's report. I thoroughly recommend the board agree this statement on modern slavery, given things that we're hearing in society at the moment about where outbreaks and where working conditions in certain factories and areas aren't what they need to be in the UK. I think we've got a good track record on this, and that some of the public contracts that we have do insist that our supply chain has its integrity, and we should take some comfort from that. So that was my first comment. Okay. I guess I want to go back to strategy, but do we want to wait for that?
You're on screen. I think we can cope with going back a little bit and getting back on track. So thank you.
Okay then. So I wanted to make a comment on what Ursula had said, having given us page 62 in our documentation and promising a dashboard on strategy later. We want to keep coming back and reporting to the board more regularly on this. We've done it through board subcommittee. By its nature, strategies is something that we can have quarterly targets on and have a short-term dashboard for, but we do want to bring it more into the board's forward thinking.
Oh. We were doing so well. Okay, I think we got the gist of what Caroline was going to say. So let's move on, and hopefully she'll forgive me. Let's go to Did
you get any of that?
I think we got the usual 80%, Caroline, which was the dashboard of strategy, etc., and how important it was. We need to report them. We'll bring it back into board. So on a
I was wanting
basis.
to make the connection to the NHS long-term plan and the Cambridge and Peterborough long-term plan, and then the North West Anglia long-term plan. Ursula will keep reporting against our delivery on that to make sure we deliver the things that we promised to do.
Okay. Point made, Caroline, and a very important point, and apologies for missing you first time. So and apologies, Taff, I've taken some of your time, so I'll go back to the questions, Taff, on your in terms of questions questions. I think Bev's got a comment and Sarah's got a question. So let's go to Bev first, then Sarah.
Thanks, Chair. I do have two comments. One is about modern slavery, and I absolutely welcome and support what Caroline said. I think also we need to remind ourselves that there's a safeguarding issue as well. So we may see as patients people who are victims of modern slavery, and ensuring that, you know, we report it wherever we need to report it fearlessly. So I think that's important, but really welcome that. The other point I was going to make, Taff, was just to say it was, you know, the BAF and risk registers have been read in all the committees, but it is very pleasing to see that that they are all in date now. So thank you.
Okay, thank you for that, and also I endorse that comment. So Sarah, you have a question?
I've got a comment first, if I may, Chair, which feeds on from Bev's comment to say that in QAC we did look at the BAF, particularly objectives 1B, and concurred through what we'd seen and heard at the meeting with the ratings that are presented in this report to board. My question, if I may, is a more general question, Taff, and I'm not sure whether it's fair for yourself or other executive colleagues. We've discussed a lot over the last few months, particularly in light of what the Trust has experienced with COVID, health inequalities in the north of Peterborough and Cambridgeshire. And I know, Chair, you particularly have been progressing this at a chair level with the Chief Executive through the STP. I wondered whether that work ought to be reflected in our draft objectives for 2021. It's not currently, I'm not sure whether it's appropriate to do so for this forthcoming year, but I'd be interested in getting a view from fellow board members around that.
Okay, Caroline, do you want to respond to that?
I think on the health inequalities, we've covered all that we should do in the right committees, haven't we? So we've said that we'll cover it in quality committee, as mentioned earlier, and we'll cover it in our strategy. It'll be part of our forward financial investment as we address the in-hospital inequalities of staffing levels, etc. So there's not one answer I want to give to where we'll tackle health inequalities. It should be in everything we do in delivering our long-term plan.
So Sarah, just to add to that, where we got to with STP is a consequence of our raising awareness, but also I think it's a national push anyway. This is health inequalities has become, not for 21 but for 20, a priority for the STP. It's the 6th priority, so we've got to find a way to weave it into the work that we're doing this year. I think it will develop, and I think it will create a for 2021 we'll actually develop that. So I think it's a point we acknowledge, and we'll take it into the thinking, but it's got to really, I'd like us to start thinking about it in more detail now, and we'll work on that going forward, if we may.
Yes, Chair. I mean, I think absolutely. In taking away from this meeting, I wondered whether we wanted to reflect, particularly in 2A, within our BAF, a little bit more on the work that is already ongoing. That was my point, Chair. But happy to have a discussion outside of the meeting. Thank you.
Thank you. We'll do that. Thank you. Mike, I think that you're invited to comment on the internal audit, I think, or external audit. Forgive me. What, Mike, do you want to come through?
Yeah, it was the internal audit plan, I think, Rob, and just to say that we discussed that plan in some detail at the audit committee a couple of weeks ago. One of the features this year is that we have created some more capacity for contingent days, as we expect there'll be a number of areas might emerge during the year that we want to take a look at. So an example would be around some of the divisional governance things that were in an internal audit report we may want to look at again, and we talked about some data issues on RTT this morning. Yeah. So we've got a few contingency days to cover that as the year progresses.
Okay, And how will you come to that conclusion going forward? Just through the committee will make that decision, is that correct?
It will be proposed, the execs will kind of propose where it is with the internal auditors, and then we'll get endorsed at the audit committee.
Okay, thank you for that. Any further questions? Joel, I think you've either got a comment, hopefully you've got a comment, Joel?
Yeah, sorry, it's a bit intermittent, isn't it, back and forth with the teams. Just in terms of health and inequalities, just building on the previous conversation, just to add the extent to which it's featuring now across all of the works and all of the different various work streams. One of the things I do is also represent the trust charity with other representatives of charities from our partners across the Cambridge and Peterborough STP, which is chaired by Julie Spence, who's Rob's equivalent at CPFT. And one of the things we are looking at is putting together an STP bid for some of the national monies that have been raised through NHS charities together during the COVID pandemic, with a particular lens on looking at how we can how we put a bid together to support inequalities in the charitable setting as well across the various trusts that we all represent. So it really is truly spanning the work across all our different portfolios and across all service lines at the moment.
Thank you, Joel, for that clarity. So thank you for that. I think there's two things we need to approve here. So the first thing is to approve the board assurance framework. I think I've had some positive feedback. So am I okay to approve that and for us to go on our way? Looks like that's all okay. No, thank you very much. We recognise the monthly risk report and also acknowledge the fact that all risks are up to date. So that's good to see and good to hear. And I'm not hearing any objection to the Modern Day Slavery Act statement that we are approving. I'm okay to approve that on your behalf?
Yep.
Yeah. Okay, thank you, Taff, for your report. Thank you, and you have your approval that you've requested. So let's move to the next part of the agenda, which is assurance updates. So Louise, you've got the next two items to talk to, which is lessons learned, feedback, and also health and safety and reports. So Louise, do you want to take us through your first is for review and
yes, I've got lessons.
You've also got good to outstanding as well. So I'll leave that to you.
So if I go with lessons learned and then good to outstanding and then on to health and safety, that was the order I was going to do it in.
Thank you.
So just really quickly around lessons learned, we started a piece of work to pick up the lessons learned from staff, feedback from staff about the whole COVID experience, what it's felt like to them, what do we need to do differently as leaders in the organisation, how has communications felt generally, you know, what could we do differently, what could we learn from it, what went really well and we ought to hold on to going forward. So the slides really just talk about how we might pull some of that together, but also make the point that we will use information from other quarters. So the staff survey from 2019, with the results of which were published in February, and it's due to be done again this autumn, and the cultural barometer, which I talked about earlier on. Also the medical engagement survey, so the work that Kanchan's been doing with the doctors and the listening events there will be pulled into an action plan, and we'll also weave that in, and also some of the survey work that the emergency planning team are doing to think about that. And then on the next slide, there's just a sort of a 4-block diagram that helps you see how we are planning to take this through. The governance for this is very much around the Good to Outstanding Programme Board, which we'll be bringing back into August and September, and then there'll be full reports back into the board. So out of it all, as you might expect, there will be action plans and really clear actions that we'll need to take, and it'll feed back through into those specific work streams from good to outstanding, which I'll talk about in a moment. So it's just really to give people a bit of an update on where we are, very high level plan that's starting to roll forward. The next one, and I'll stop after this one for questions, the next one was around Good to Outstanding, which has been running for some time. We refreshed it in 2019. It's essentially a brand that survived in Peterborough, was developed in Peterborough pre-merger. Hinchinbrook had something similar. We did some work at merger and we managed to retain the brand, and we've just refreshed the brand last year and refocused some of the work streams. So as you can see, we've got executive leads for all of the work streams. We just need to reallocate allocate outstanding health and well-being, and that should be confirmed shortly. But actually we want to make sure that whatever we've got in those action plans currently is going to be really current and is prioritised, linked to what's come out of COVID. So we'd previously agreed that health and well-being was top of the list. We would do a lot with that. We needed to really focus on that with staff, and in fact you can see in the following slides, I'm not going to go through these, but we've given you a flavour of the things that we've been doing through COVID and what we might want to pick up as a recovery focus, so linked to the work that we're doing around recovery and that our Shear is leading. So it was really just to try and give you a feel. Out of everything, there'll be an action plan for September that will come back, and we'll use the Good to Outstanding board, which meets monthly, to make sure that we're fleshing out and prioritising all of the actions for each of the work streams. So I wasn't particularly going to dwell on that, but it was simply to try and give people an oversight of the structure and the mechanics of how we're going to take things forward. Happy to take questions before I talk about health and safety.
Okay, while we're thinking, I just had a comment that obviously at our board workshop at the end of August, we'll take into account lessons learned from the work that Louise has taken us through. So we will we'll end up with a full board report that we can add to our lessons learned. So how we work as well as a board, etc. So we've had to adapt and adjust how we've operated in what's called governance light, and so we also take that into account.
Okay.
Thank you.
Thank you.
So I think we can move on to the annual health and safety report, which is for approval. So we'll listen to you very carefully.
Yeah, again, I'm going to take this as read. It's a rather long report, but we've got a legal obligation to make sure that we publish an annual health and safety report, and the focus in here is mostly around non-clinical incidents. You'll see from the text that we've woven in some of the COVID work that we've been doing, because that has been a lot about managing risk, albeit this goes up to the 31st of March, this report, and we'd only just started with COVID at that point. It kicked in mid-March. So we're required to publish this annually. It's already been considered through the Health, Safety and Security Committee and through Hospital Management Committee and through People and Performance Committee on Friday, who recommended it for the board. The only action that came out of People and Performance was a request for me to make sure that we have some very clear actions and priorities for health and safety for 2021. The team have already got those, but I need to flesh them out on the back of COVID, and we can share those with PPC again. So I commend the report to you and ask for approval, please.
Okay, so am I seeing approval of this report?
Yeah.
Or questions? Yeah, Bev, I think we've got a comment, perhaps, please.
Yes, thank you, Chair. The comment was, which Louise very quickly made for me, we endorsed this at People and Performance with the caveat that we'd see a very strong, robust plan going forward about health and safety priorities. But what it was very good to see, we've started to see things that we were paying attention on in the committee. We're starting to see a turnaround on some of those. For example, needle stick injuries. You know, it was an all-time. There was a peak last year, and this year it's been paid attention to, and that peak has reduced markedly.
Okay.
So that's all I wanted to say. Thank you, Chair.
Thank you. So I'm seeing approvals coming through. So Louise, that's okay to proceed with that report. Thank you. You have approval.
Thank you.
Thank you, Louise. So let us move on to next item, which is learning from death, which is for review, and Kanchan will take us through this. Dr. Rugge, thank you.
Thank you, Chair. So this is part of my quarterly update about learning from deaths. As you recall, this initiative commenced in 2017. We underwent our structured judgment review training in June 2017 and published our policy on the internet in September 2017. The structured judgment review is basically a way of reviewing deaths. It's a certain methodology which is explained in the paper. We've obviously done a lot of work looking at our deaths that have unfortunately occurred during the pandemic. You're aware that 250 people have lost their lives out of 900 patients who were found to be COVID positive during the period of the pandemic. We've selected patients particularly for structured judgment reviews, and you will see how they have been analysed in the papers here. There are two different ways of examining the deaths. One is a very detailed multidisciplinary approach, the structured judgment review, the SJR, and the other is the NCPOD method, which involves a team reviewing its own deaths. I think it's worth saying, particularly because the last time we met back in March, we were talking about the ethics panel and the possibility, having seen what happened across the world, that we might be having to be in a position to ration care. We never got to that position, so we never had to limit access to intensive care services, and we have had people who were admitted to ICU over the age of 70 who in fact have done very well. Equally, our youngest death, a patient who was only 30 years old, was a patient with severe autism who also was escalated to intensive care. So I just want to reassure the board that we haven't had to deprive anyone of what we would view as being the most intensive care that we could offer. In total, we have reviewed 51% of all our deaths, and now that we're getting more back to business as usual, we'll be reviewing the outstanding deaths with COVID that meet our criteria through the structured judgment review process. And to reassure you that, as you can see again, that 74% of all care has been judged by peers as being of good or excellent standard.
Thank you, Kanchan. Was this report discussed at QAC? No, so no, this has come straight.
No, it's come straight to board.
Okay, so Mary, you have a comment?
Thank you. My comment really is just to commend the examples of care in the slide on lessons from care that did go well, because amidst all the other things that are the drama and the media coverage of COVID in particular, what this evidences, I think, is really good, solid care of patients who were going to lose their lives with us. And I think it's a very good example of just what some of our staff are up against and how they went to meet it. It's a very, very good illustration. It's a little too complex to get much media attention, but it really is good and heartwarming.
Thank you for that comment, Mary. So, Sarah, you have a question?
If I may, Chair, and would absolutely endorse what Mary's just said. I've got two quick questions. The first, Kanchan, is have you got the capacity to undertake all of the SJRs that you're seeking to do over the next few months? And secondly, I know you started a recruitment process for medical examiners, and we paused it for a while. I wonder whether there's any new guidance from NHS-IE in terms of whether we are now required to implement them or not. Thank you.
Yes, so we have been advised to move to the medical examiner method of working now. In fact, during the pandemic, we sort of almost adopted a medical examiner schedule, in that only the histopathologists were doing death certificates to speed up the process. And additionally, because we were using electronic notes, we were running a very slick service, and the bereaved relatives actually got very prompt service from us, so that was a sort of minor achievement, if you want to look at it in that sad way. But yes, the medical examiner initiative is progressing.
Thank you very much.
And if I may, sorry,
yes,
Chair, may I just ask, just the first question, Kanchan, just have you got capacity to undertake all of the SJRs that you've got to get through?
Yes, I understand. So I haven't heard otherwise. I think it's quite important for all clinical staff to have a period of reflection, and the SJR allows them to do that, because some of the deaths, particularly at the height, were very shocking because people died very quickly. And when I did my couple of clinical shifts, I was surprised at not at how quickly they died, but how upset the junior staff were with the events that happened. So certainly when we were doing the medical redeployment of people from areas that they were unfamiliar with, for example, surgery, to the medical wards, the pastoral care that a senior doctor could give to juniors who were unfamiliar with so many people dying at the same time was very important. So I think a period of reflection would actually serve everyone well.
Thank you.
Thank you, Kanchan, for adding that insight, which is really special, on top of, takes us away from the raw data to show that these are challenging times for families, but also for our staff to do. So thank you for that. I'm going to move on to the next and final item that we have report-wise anyway. So I've got a raising concerns report. I'm not sure, is Caroline, are you going to lead us on this, or? Yeah, so is Caroline, are you leading this, or is Sally going to do this?
I'm hoping that Sally's joined the call and that we've allowed her into the meeting. It's important that as our Freedom Speak Up Guardian, she gets to speak freely to the board without me controlling what she says.
Okay, well, I'm
happy to present this.
No, I'm a little early for the time. So it's scheduled for 4 o'clock.
Okay, so Grant's going to give her a call.
Yeah, so what I thought we'd do is, could we move on to any other business? Do we have any? No, I think we're just checking if Sally's around. Yeah, Sally's about to join us, so we'll wait for Sally. That's okay.
Hi, I'm here.
Thank you. So you've saved my bacon. Thank you for that. So welcome, Sally. I can't see. Yes, I can see you now. So thank you for joining us. And we are a little early for you, so sorry for being early. So very happy to receive your report. Perhaps you could start with letting everyone know, because this is going out to public, who you are and what you do, and then take us through the report. Thank you, Sally.
Hi, so I'm Sally Mumford, the Freedom to Speak Up Guardian for the Trust, and the positives from the report this month is that, or the quarter, is that the numbers continue to increase. So people are still coming forward to us and raising their concerns. The themes are very similar to last quarter, and where the issues are coming from. And we've also had this quarter, there's been a problem with uploading data to the National Guardian's Office, in that they haven't asked for the data during the COVID period. They reopened their submission portal last week, so we've just done that. And what they have done is publish their annual Freedom to Speak Up Index, which is based on questions from the staff survey, the National Staff Survey. And we are slightly above the national average, in that the national average is 78.7% and our score is 80%. So a little bit of a decrease from last year, but still above national average, and still have a lot of people coming forward to speak to us.
So above is good, Sally, is that right?
Yes, yeah.
just,
definitely.
just to check. So thank you for your report. Are there some headlines, additional headlines you want to make, or is it much the same as last quarter?
Yeah, much the same as last quarter. There's a lot of work going on, so I've had quite a lot of contact with the Guardians from around the patch in the local network, so Papworth, Addenbrooke's, Cambridgeshire Community Services. They're all reporting an increase in the contacts that they're having with the concerns being raised, and very similar to here, they've been contacts around PPE and decision making during the COVID period, so it's kind of very similar themes across the patch for us.
Okay, Caroline, you've got a comment. Over to Caroline, please.
Just to compliment and add to what Sally said there. Whilst you were double checking there, a rising numbers of people raising concerns is a good thing or a bad thing. It's definitely a good thing. We wish there were no concerns, but people feeling free enough to raise a concern and to speak to somebody in confidence like Sally is definitely a good thing to do that. And certainly throughout the pandemic, we were encouraging people to speak out rather than feel that they didn't have a voice and that they couldn't speak out, specifically about things like PPE. If they felt they weren't getting answers to questions or felt unsafe, in an environment. It's just one of the routes that staff could use to speak out about feeling unsafe or unhappy in their work environment. And that was a national push as well to make sure that we weren't closing down routes for staff to speak out when they had concerns about the working environment. So I think it's good that people have spoke out in numbers like this. And as Sally said, it's a picture that other trusts have seen as well. And I think I have a regular meeting with Sally. From the feedback we've had, she definitely deals with some of those concerns and reassures some people of the environment they're in, and gives them some support that they're not getting in their normal environment to help them.
Okay, thank you, Caroline. Do we have any comments or questions from around the room? I'll ask one while we're thinking. So we had a patient survey feedback the first part of the meeting, and part of the feedback was that they weren't fully representative of our community in terms of the demographic and the ethnicity. What would your comment be for staff? Are you getting sort of certain groups, or is it sort of just a complete mix? And any additional comments to that point?
So I don't think that it is representative of the staff group that we have, and we know nationally and locally that there are issues accessing certain groups. So we know that our BAME community, for example, doesn't speak up as much as other members of staff. So I'm doing some work with Simon Howard around that in terms of linking into the EDI steering group, and also joining the BAME network and some of the other networks that he's got running to raise awareness of speaking up and make sure that people know how to access this and make sure that they can come forwards and speak up. But I'd say that it's not representative at the moment, but again, not outside of what we see as a national picture.
Okay, I see Bev has a comment. Bev, you've got a comment?
Yeah, thanks, Chair. Thanks for that, Sally. Really good report, and I was really pleased to hear your response to that, because I'm the NED lead for diversity and inclusion, and it is one of the things that's been exercising us is how do you get into members of staff and patient groups that don't necessarily access the normal routes. So thank you, and I look forward to working with you on it.
Excellent, thank you.
Okay, I don't see any further questions, but I really thank you for the work you do. I think you're you're no longer new. This is you're well in your stride. So I enjoy the meetings I have with you and with Caroline. So keep up the good work, and thank you, Sally.
Thank you.
So let's move on. I asked for any other business, and there wasn't any comments. So on that basis, I'm going to move on to the final part of the agenda, which is questions received. So just to remind everybody, we are now, because of MS Teams Live, we are able to connect with more people, and we've sent out a questionnaire to all the members to say, so the request, if you've got questions to ask the board on the board agenda papers, we're very happy to receive them. So we'll keep working to achieve that. We receive the questions by close of the day on Sunday, then we are able to prepare some answers. So we have 6 questions today. We will write the answers in full in the minutes, but what I'm going to do is ask the question on behalf of the questioner, and then I'll ask the individual executive director to respond. So we have 6 questions, and the first question is from Sue. Well, we've got 3 questions from Sue Pryor. The first question is on strategy and governance, and this is a question for TAF, and it refers to page 10 and 11 of the executive summary and the collective review of risk governance. And I'll be seeking reassurance that as a council of governors, we will be continue to be updated on risk and its governance, which has continually improved in the last year, despite any changes in the governance process. So TAF, do you want to answer that question, please?
Thank you, Chair, and thanks to Sue for the question. I suppose where I'll start is any changes that would make to our system of governance in relation to risk or any other policy would need to come to board for approval. So the the public and the governors will be able to see the revised risk policy before it's approved at public board. I'm cognizant that why the question has been raised by Sue, and I'm conscious that the Council of Governors, part of their role requires that they test the robustness of our risk management processes, and therefore I'm happy to work with the Council of Governors as required to do some work to explain all the changes that we're making and why we're making those changes. At the last Council of Governors meeting, the chair had highlighted that we will agree a program for the year. I'm happy for that to be fed into that conversation about whether we need to hold a risk session with the Council of Governors to provide any more detail that is required to ensure they can fulfill their responsibilities effectively.
Okay, Tafa, thank you. I'll add to that in terms of we are working with on a plan of workshops, and I'll sit down with League Governor and we'll and yourself, and we'll put that into a workshop going forward. So thank you for that. Hopefully that answers the question for Sue, but we'll communicate this in the minutes of our meeting. Next question is on finance. It's for a question for Joel, and it's regarding capital programme. That's the key message on page 8. And it says, are the figures stated as per forecast, and what impact, if any, has COVID had on the forecast? Joel.
Thank you, Chairman. So the Trust's capital programme is exclusive of any COVID-related capital expenditure. We have developed a revised capital programme in the context of what's happened to us as a consequence of COVID, but it does not reflect any COVID expenditure. The COVID expenditure falls outside of the Trust's normal business as usual capital programme. So of the 8.1 million included in the finance key messages, as it says, 3.8 million of that has been spent on COVID related expenditure, but it is the 4.3 million non-COVID related capital that compares to the Trust's capital programme.
Thank you, Joel. Thanks. That's very, very clear. I'll move on to the final question from Sue, which is on quality, pages 31 to 33. It's about mortality, and the question is, in previous governor meetings, the lack of sufficient respiratory consultants had been mentioned as a concern by the NED's re-COVID treatment. Whilst noting the ongoing review with the shortage to be considered in the current review for respiratory death in HRMS and SHMI, what actions can be taken to support the clinical area from other trusts whilst recruitment in this scarce resource is ongoing? Kanchan.
Thank you. So a couple of points really. Whenever our shimmy goes up, and shimmy is thought to be a more comprehensive review, a more comprehensive indicator of our mortality than HSMR, which only applies to about a quarter of the deaths within the trust. And whenever the shimmy goes up, we do tend to have a large respiratory component of those deaths, which we have historically attributed to the levels of smoking in inner city Peterborough and Fenland, because we are outliers in this respect in the east of England. So that's to say we have a lot of respiratory deaths anyway, and even when we had a full complement of respiratory physicians, that was our a very significant cause of death. But at the moment, it's true to say we are very worried about the shortage of respiratory physicians across the whole trust, Hinchinbrook and Peterborough, and that's really been pointed up during the pandemic, obviously. Prior to the pandemic, we did have a review by the GIRFT initiative, Get It Right First Time. And one of the things that they noted was that when you are in the periphery of a specialist hospital, for example, our relationship with Papworth that we've seen a little bit with cardiology, is that recruitment is extra difficult because people in our areas would naturally be drawn to the teaching hospital or the tertiary centre rather than a district hospital. So GIRFT have come up with some proposals for enhancing the number of services or the repertoire that we offer. And as we know, newly appointed consultants do like to have specialist interests rather than offering a general level of care. So we discussed this with CCG colleagues at the Quality Assurance Committee yesterday, and as soon as I get the GIRFT report, I'll be sharing it with the medical director and the chief nurse of the CCG to do everything we can to increase our offer to attract new consultants.
Thank you, Kanchan. Thank you for that response, and I wish you luck with that. Because it is important that we address that. The next question, we've got 3 questions from Kevin Burdett. He's our lead governor, and the first one I alluded to a bit in my report, which I guess is why Kevin's asking the question, but basically it's about board governor ward walkabouts. And the question is, I understand the current difficulty in using this way to assess the patient experience, but would suggest that there's some urgency in establishing some form of system to provide assurance. So I guess the question is, what are we doing to address this area that we no longer can do? Jo.
Thank you, and thank you for the question. So this is a piece of work we've been undertaking with the matrons and the ward managers after some discussions we've had at the Quality Assurance Committee around triangulation of some of the KPI data that we've been sharing at Quality Assurance. So it's in its infancy at the moment, but we have recommenced the walkabouts with the matrons, and they're all scheduled in the diaries. We have been undertaking environmental walkabouts because of the infection control element of COVID with both the divisional teams and the infection control team and some of the senior nursing team. Collation and theming of complaints and PALS concerns and the lessons learned are really important to help us look at whether what we feel is going on and the KPIs we're seeing is the patient experience that the patients are having. We're also, on a positive note, looking at the accolades and the good news stories that are coming through from the clinical areas. We have plans to recommence our cruise assessment schedule in September, and we've already earmarked the new ward areas and a new format for undertaking the cruise assessment. The weekly walkabouts with Caroline as the chief exec, myself and the nominated matron are scheduled as well. What we have suggested we would do with some of the ward teams, and I discussed this with the matrons, was being able to review any of the ward areas that are alerting or on our worry list through an MS Teams virtual medium, so that we could invite certain members of the team to join with a panel that is on MS Teams, so there could be bit more check and challenge. But we're also looking at how we can use the iPads with the camera for more virtual tours and bring documentation up through MS Teams for review with external stakeholders and with our NEDs and obviously governors. We have talked about if we could get patient consent, whether patients would be happy to have some Skype sessions with either governors or non-execs to share their patient experience while they've been in. We've been using Skype and various other fora to enable our patients to talk to their carers or family members. So with their consent, that's another way for us to get a different viewpoint. And we are looking at what a small group of external stakeholders would look like to walk around the wards. However, what we want to do is restart visiting on the 3rd of August, which is our start date, and just monitor how the reintroduction of visitors to our patient goes around our infection control rates before we actually bring other people into the organisation. There's still more work that we're working on with the ward managers, and we're keen that they come up with some real innovative ideas. Ideally, if we could have like the gaming screen bits, that would be great, but I don't think that's something we can do in healthcare. And the thought of all of the clinicians and people walking around with these screens on would be interesting. But lots and lots of ideas coming up so that we can assure people that the care delivery and standards haven't dropped at all during COVID, and that what you're seeing in data is actually what's happening in practice.
Thank you for that. There's lots of ideas that you are sharing, Joe. I'm sure that we'll come to a set that we can focus on. But thank you, and also just to reinforce the point, infection control is really important, and we don't want outbreaks to occur. But thank you for your response. The next question is again from Kevin. It's about the STP, and his question is: I appreciate the hard work and cooperation has taken place in the STP in recent months. And the question is, how will you guard against the STP slipping back to previous ways that paid little attention to health inequalities, etc., once systems are back to something like normal activity? So this is something that Caroline and I are keen to work on and to promote. I would say that the STP has learned a lot from its response to COVID. So the learnings are being taken into account. We're working more closely, certainly over the next 6 months, as we try and get back to normal. I think I mentioned before that what keeps health inequalities on the agenda is the fact that it's now on being recognised as a priority, but also in addition, nationally there's focus on it. So I think that with having on the STP priorities and the national focus, plus what we can do locally as well, I think that's going to give us keep the focus and the momentum going. In addition to that, I have weekly calls with the STP Chairs Group, and we meet monthly as STP board. So rest assured that Karen and I will continue to make sure that we keep the focus on this. The final question is about, it's a question for Caroline, it's about reorganisation of services. And the question is, as reorganisations provided at our different sites take place, how will staff be involved in consultation? He's asking the question because he's had conversations recently with staff from Hinchinbrook Hospital indicating that morale is low. Many feel that PCH is dictating to them and decisions affecting them are a fait accompli and made too remotely. So a whole range of questions in one question, but Caroline, I thought this was one that you could answer. So over to you.
Thank you, Chairman. So there's a couple of parts to this, as you say. First of all, I'll cover the bit about the changes. We are making changes to our services to cope with what's in front of us and keep infection prevention control at the front of everything we do. And during the pandemic earlier phases, when we were close to the peak, we made some of those changes very quick and didn't necessarily consult everybody as we normally would about some of those things. So a little bit of it was about in the heat of the pandemic under command and control. We were telling people on both sites, not just Hinchinbrook site, what to do out of necessity and need to surge our capacity. And now as we're going to phase 3, we're making further changes to services. As I said earlier, some of it in line with our strategy anyway, like moving trauma to the Peterborough site from the orthopaedic trauma on the Hinchinbrook site, or changing some of our services to keep green and red sites more integral to services to maintain infection control. But just to reassure everybody, we are involving lots of people in those decisions. We are taking on board comments and we are getting clinical feedback into those. And indeed, we had planned to do the trauma switch very quickly before phase 3 started, and we're planning on that over the last few weeks, but we've delayed that now to take on board more feedback and certainly address some of the concerns Peterborough staff have mentioned actually about staff safety and patient safety if we did things too quickly and didn't get it right. So we're taking a bit more time to take on board some changes, and we will do that now. It's a normal part of our management to have input into anything changes that we do. The current phrase in the NHS is co-production, but it's about engagement in all that we do in changes. So that is a feature and will be a feature, but it's felt a bit like it wasn't the norm during the pandemic, which I can apologise for, but that was a necessity at the time. I think the specific about Hinchinbrook is a feature that's been with us for the 3 years, and some of it's come to the forefront because we did manage the pandemic from the control room at Peterborough for the last 4 months. So more than ever, the Hinchinbrook site felt as if they were being told what to do by the Peterborough leadership team, rather than it feeling like it was the NWAFT leadership team telling the whole trust what to do, which is exactly what it was. And we did change some things during the first few weeks to get a Hinchinbrook cell to the control team and to have representation down here, but it clearly wasn't felt as quickly as it should, and some views from the Hinchinbrook site were felt not to be taken on board. So we've got to do more on this. We're as an executive team, we're thinking about what we can do to re-engage the whole cultural shift that's required for North West Anglia. It's part of the good to outstanding that Louise mentioned earlier. And certainly some of the medical engagement events that Kanshin mentioned earlier that we've both had over the last few weeks around how to involve clinicians in everything we do and be clinically led. The feedback we've had there has been a bit Peterborough versus Hinchinbrook again. So we just need to keep going on what we're doing and try and make things feel as balanced as they can be, and accept that things feel different on the Hinchinbrook site for very valid reasons. We merged, say we wanted to take the best of both previous organisations, and we need to make sure that that's understood and clear to everybody as we keep going, even though we are in year 4 of the merger now. Thank you.
Thank you, Caroline. Thank you, and thank you, Kevin and Sue, for your questions. As I say, we'll publish these in our minutes. We've come to the end of the meeting, so I want to thank all the participants involved, both in front of the camera and behind the camera. I'd like to thank the World Wide Web for making this meeting possible. The next meeting, the next public meeting, it says private meeting, I think it should say public meeting, is Tuesday the 29th of September, and that's an MS Teams live event, which is the same type of you've seen today, and that's between 2 o'clock and 4:15. Thank you very much, and thank you for listening and thank you for watching. Bye now.